Moving on to the next case, we have a case of a 3 centimeter solitary thyroid nodule in a 26-year-old lady. And to discuss this case, I'd like to invite the moderator, respected Dr. Raman Marwaha sir. Sir has been the former additional director and head of the Department of Endocrinology and Thyroid Research at INMAS, DRDO. We welcome you, sir. Now I'd like to invite the panelists for the discussion. I'd like to welcome Dr. Nishikant Damble, who is the additional professor at the Department of Nuclear Medicine at AIIMS, New Delhi. Further, I'd invite Dr. Vivek Agarwal, who's an endocrine surgeon at the B.L. Kapoor Hospital, and Dr. Monica Garg, she's a senior consultant in the Department of Radiology at the Maharaja Agrasen Hospital, New Delhi. Now I'd request Dr. Raman Marwaha to please begin with the proceedings for today.
Let me at the outset thank the organizers for giving us this opportunity to discuss this case, and I welcome my experts here to discuss a case of thyroid nodule in a female, 26-year-old female, the size of the nodule being about 3 centimeters approximately. So this is the case presentation. We don't have detailed presentation so that we can discuss at length the presentation of a nodule as such, and finally we will limit ourselves later on to the differential benign nodule and carcinoma on thyroid. So I will give you a little brief about the thyroid nodules before we start our discussion. And what do you find on physical examination? A nodule is considered to be present when you find a portion of the thyroid which has a very different contour or consistency than the rest of the gland. Whereas on ultrasound, if you find a focal region of a differing parachiinal ecotexture, that is what is considered to be a nodule. So only 10% of the total nodules are clinically palpable. So 90% of the nodules will not be able to palpate. And of these 10%, 7 to 9% of those thyroid nodules which are detected clinically or on ultrasound, they are differentiated thyroid cancers of follicular cell origin. Risk of malignancy, both in the solitary as well as multiple nodule, is the same. Earlier days we used to consider multinodular gland or multinodular gland to be benign, but it is no more true. You can have adequate number of cases who will be found to be malignant in a multinodular goiter. Up to 30% of the thyroid glands harbored malignant nodules, which is less than 1 centimeter, what we call as microcarcinoma. Most of the microcarcinomas lack the potential to become biologically significant, and they usually have a very indolent course. That means they don't generally become malignant and spread at distances. A very small percentage of these microcarcinomas do become invasive and metastasize. So this is one of our earlier work which we published in 2012, giving you the prevalence of nodules in Indian adults. We showed that there are clinically, you will find only 1.6% of the subjects to have clinical nodules, whereas on ultrasonography, it increases almost 4 times, that is 5.1% of the subjects, more so in female, have solitary nodules. Coming to children, and both these studies have been after the iodization program, which has been there for almost 3 years, and that is the reason why we have much lesser kind of prevalence of nodules now. This is the other study where 38,000 or 39,000 children were evaluated, and the clinical palpable nodules were only 2 per 1,000, that is 0.2%. And on ultrasound, the prevalence was 0.6. So what is the prevalence across the globe? Up to 8% of the adult population. I did mention initially 10%. Ultrasonically detected nodules have very, very high prevalence, unlike what we showed in our Indian population. Up to 46% of general population may have nodule or ultrasonography. And on autopsy, you will see that 50% of these cases do show a nodule. And the lifetime risk of developing a thyroid nodule, as per Framingham population study, is 5 to 10%, and the risk of malignancy in adult population is up to 10%. So with these few slides giving you the background of solitary nodule across the globe and in the Indian population, we are going to start discussing the case of a lady, 26-year-old lady, who presents with a solitary nodule. So my first question goes to Dr. Damle as to how would you go about clinically evaluating a case of a solitary nodule in this 26-year-old lady, which measures about approximately 3 centimeters in diameter.
So good afternoon, everybody. It's a pleasure to share the dais with Dr. Marwaha and my colleagues, Dr. Vivek and Dr. Monica. So coming to this question that sir has asked as to how we should approach a patient who comes with a solitary thyroid nodule, in this case measuring about 3 centimeters. Now this is a very frequent occurrence that...
Can you be a bit louder?
So this is a very... Am I audible to you?
Yeah.
Okay. So this is a very frequent occurrence that we see in our clinics. Now whenever a patient comes with a thyroid nodule, usually they will just present with swelling in the midline or the paratracheal location. They'll come and say, Dr. Saab, yahan pe. So they'll come and say, Dr. Saab, there was a swelling and it's gradually increasing in size, or they may say this has been persistent for a very long time. So when you look at that patient, you should first ask and observe. So inspection and palpation, I think should go together along with the history. So in history, you should ask them significantly, does this swelling move on deglutition, which you can actually see also, and ask the patient to swallow and confirm. After you have confirmed that it is a thyroid nodule, you should ask for associated symptoms of hyper or hypothyroidism. So we are all familiar with the symptoms of hyperthyroidism as well as hypothyroidism. On examination, you can look for eye signs if there are any. You can look for the size of the gland. In palpation, you should look for the consistency of the nodule, whether it is a hard nodule, whether it is a firm nodule, or whether it is soft in nature. So hard nodules are usually malignant. Firm nodules can be seen in Hashimoto's thyroiditis, and generally the gland in Graves' disease would not be nodular, it would be diffuse and soft. Now other than that, we have to see if the nodule is associated with any lateral cervical swellings. Are there any lymph nodes that we can palpate? Other than that, we have to see the fixity of the nodule and ask the patient specifically if there is any change in the voice of the patient. Now, after having asked these questions and done a preliminary observation, we must also ask for one very significant thing, that is radiation exposure in childhood. So, thyroid carcinoma is one of the malignancies which are known to be linked to radiation exposure in childhood, even in adulthood, but mainly in childhood. So, if you read literature, there were spurts of thyroid cancer after the Hiroshima and Nagasaki incidents in Japan and the Chernobyl nuclear disaster in Ukraine. So up to 30 years after those incidents, there was occurrence of thyroid carcinoma in a lot of people. Other than that, there could have been radiation exposure due to medical reasons. So in the past, craniospinal irradiation was used for ALL, and a lot of indications where we don't use radiation now, including, fungal infections, acne, and, a lot of indications were described in the past. And in a busy thyroid clinic, you would often find somebody who gives this kind of a history that yes, there was radiation exposure in the past. So these are the points in the history that you have to ask. Now vis-a-vis how fast the nodule is growing. So generally we have to keep it in mind that most of the nodules would be benign, as sir has shown that about 10% of them would be malignant, and nodules are a ubiquitous finding. In the Indian population, it has been described up to 50% in ultrasound studies. In some autopsy series, internationally if you read, nodules have been described to occur in up to 80% of the population also. So prevalence of nodules should not be an alarming factor to any of us, but the nature of the nodule and the history is very important here.
Thank you, Dr. Damble. But one thing that I'd like to add is that family history of malignant thyroid nodule is also important, because 5 to 10% of these malignant nodules are known to occur in the family. So family history of thyroid malignancy is also what I think probably he missed out.
So regarding the point that Dr. Marwaha has raised, so family history is definitely important, and not only in medullary thyroid carcinomas but also in papillary thyroid carcinomas.
Yeah.
Also there are a host of syndromes that are associated with papillary thyroid carcinoma, including Cowden syndrome, Carney's complex. Often you would find a case which has this kind of a history. So family history is definitely important. Radiation history is important. The age of presentation is also important. And the rapidity of onset is of utmost importance.
Yeah. Thank you. My next question goes to Dr. Vivek Agarwal. How do you classify thyroid tumors, and what all investigations would you like to undertake in a case presenting with a solitary nodule?
Well, thyroid nodules as per WHO classification are divided into various headings like
can you be a little faster? We are running short of time. Yeah.
so one is like
Louder.
follicular cell origin malignancies, then C cell origin malignancies, then you have mixed follicular and C cell origin malignancies, you have salivary gland like malignancies of thyroid, you have thymic tumors within thyroid, you have tumors of uncertain histogenesis, and embryonal cell derived malignancies, that is something like thyroblastoma. And most important and most common malignancies is this follicular cell origin malignancies, which we also call as well differentiated carcinomas. And follicular cell origin tumors are further subdivided into benign nodules, nodules with low risk malignant potential, and clear cut carcinomas. So most important of this is a subset of group which has got low risk malignant potential, and there are usually 3 varieties which have been described: thyroid tumor of low risk malignant potential, hyalinizing trabecular origin, and well encapsulated follicular lesion with some papillary like features. It's a non-invasive kind of entity which was earlier clubbed with carcinomas. So identifying these, and these have now the word carcinoma has been removed, and rather only tumors have been used for this subgroup. And the clinical implication is that they practically behave like benign tumors. So the management is far less aggressive than what we do for malignant cells. Another common tumor is of C cell origin, that is medullary cell carcinoma. So these are what we commonly encounter in our clinical practice. Now whenever we have such a patient of 3 centimeter nodule, the primary concern is whether the nodule is malignant or not, and secondarily whether it is associated with any hormonal abnormalities. So as Dr. Nishikant already told that we have to look for features of hypothyroidism and hyperthyroidism, and also get a thyroid function test, that is 3,3-T4 TSH, to ensure that the nodule is, the person is euthyroid or hyper or hypothyroid. And once we have established the euthyroid status, then we would like to definitely look for or rule out malignancy by getting an ultrasound done, which has certain characteristic features described to stratify whether the nodule is malignant or not, which probably Dr. Monica will tell in more detail. And then we do a biopsy confirmation by doing a fine needle aspiration cytology. Then another important evaluation would be to look for extent of the disease using either ultrasound or maybe further investigations like CT scan in case there are associated lymphadenopathy or there are any signs of clear-cut signs of advanced malignancy. So once we have established the patient is euthyroid and it's then we look for whether it's malignant or benign. If the thyroid function tests are disturbed, like if you have a low TSH, then probably we go for some nuclear scanning to see whether the nodule or the thyroid is harboring any hyperactivity. And for that we do either a low dose iodine scan or technetium-99 thyroid scan.
Okay, here would you like to add in your investigation molecular aspects of the thyroid nodules? What is said is that if you do molecular evaluation, if you have mutated BRAF V600 gene, it is more aggressive papillary carcinoma, and if it is kind of RAS or other thing, it is more towards follicular. So molecular aspects also need to be studied when you have an indeterminate kind of a thing. Well, you did mention that ultrasound is an important investigation. Dr. Garg, would you like to highlight, ultrasound is of course a very, very important investigation in differentiating thyroid nodules. What all information can you derive out of ultrasound, if you can be brief and crisp?
Sir, ultrasound is a very important diagnostic tool in the workup of a thyroid nodule. First of all, ultrasound will tell us whether the nodule in concern is of thyroid origin or not. Then we can identify other multiple nodules, which happens in most of the cases, and the palpable nodule may not be of significance, suspicious, but the other nodule which we find on ultrasound might be suspicious. And most important role of ultrasound is to risk stratify the nodules, which we do on the basis of various classification systems available. We use ACR thyroids often. And on the basis of various ultrasound features, we assign points to the nodule, add up the points, and then place the nodule in either of the category ranging from benign to highly suspicious. And since this is a 3 centimeter nodule, and if it is if the thyroid is 5, then the nodule has to be sampled. And it is better to sample under ultrasound guidance, which is another advantage of ultrasound to guide interventions.
So, would you like to comment on the margins of the nodule, the echogenicity of the nodule in terms of malignancy, or there is microcalcification, or there is...
Yes, sir. We look at 5 features of the nodule. The composition, that is, if the nodule is cystic, spongiform, solid cystic, or solid. The more solid the nodule, the greater its chances to be malignant. Then we look at the echogenicity. We compare the echogenicity to the surrounding thyroid tissue or the strap muscle. If the nodule is less echogenic than the adjacent parenchyma, thyroid parenchyma, then there are chances of the nodule being malignant. Then we see the shape of the nodule. If the nodule is taller than wider, then it is not a good sign. Then we look at the margins. If the margins are infiltrative or there is overt extrathyroidal extension, then the nodule is likely to be malignant. And lastly, if we see punctate echogenic foci, if we see interrupted calcifications and the nodule is extending beyond the calcifications, these are the risk factors for the nodule to be malignant.
And
high chances of the nodule to
maybe also increase vascularity to some extent.
Sir, vascularity...
Well, it can be there in both benign as well as this, but
yes,
that's again
it's not a very specific
question
feature.
to Dr. Damle, I want you to be very specific and fast. Does radioiodine or technetium scan have a role in the initial evaluation, not later, in the initial evaluation as on the present day?
Yeah. So in the initial evaluation, as Dr. Vivek initially put, we have to see the TSH of the patient. If the TSH is suppressed, which indicates that there is hyperfunctioning of the gland, we need a technetium thyroid scan. In the olden days, we used to go ahead with the I-123 or I-131 scan also, but the technetium scan serves the same purpose. So this helps us in ascertaining whether the nodule itself is taking up more uptake and hyperfunctioning, or the nodule is cold and rest of the gland is hyperfunctioning. So in delineating the cause for the toxicosis that the patient has, the thyroid scan is useful.
Yeah, but it is not useful in differentiating between malignant or non-malignant, which as on today is not done for that.
Yeah.
So just answer one more question here. Does PET have any role in the initial evaluation of nodule?
According to me, PET does not have any role in the initial evaluation.
Right. Okay.
But
so this
it has a role in a specific entity called as tennis syndrome or a radiorefractory DTC, where we sometimes need to look at the extent of the disease before planning further therapy. So there it has a role.
Yeah. So this is very well said. We have carried out a study. We found that the ultrasound was as effective as PET to differentiate between benign and malignant. So it really doesn't have a role. But as he very rightly put it, it has a role where radioiodine resistant tumors or distant metastases are there. Then you can use PET to differentiate. Dr. Agarwal, you did mention about fine needle aspiration. Now, how do you classify these as per the Bethesda system? Just briefly 1, 2, 3, 4, 5, because we are running short of time. Yeah.
So Bethesda system basically classifies the risk of malignancies based on FNA, and it is divided from 1 to 6. Bethesda 1 basically is non-diagnostic, where we need to repeat FNA, and just such nodules carry risk of malignancy to a tune of 1 to 4%. Then we have Bethesda 2, which is clearly benign, and the risk of malignancy is less than 3%. We have Bethesda 3, which has lesions like atypia of uncertain significance and follicular neoplasm of undetermined significance, and here the risk of malignancy is to a tune of 15%. Then we have Bethesda 4, which includes follicular neoplasm. Here the risk is to a tune of 30%. Then we have suspicious for malignancy, that is Bethesda 5, having a risk of malignancy around 50 to 70%. And Bethesda 6, which is clearly malignant, having a very high risk of malignancy to a tune of 97 to 99%.
So if it turns out to be benign, Dr. Damle, just briefly, how would you manage? And then Dr. Agarwal, if you could take on the surgical management of this case. Damle.
Well, if the nodule turns out to be benign, then we have to see if it is associated with hyperfunctioning and thyrotoxic symptoms or no. If it is not associated with hyperfunction, then one really doesn't need to actively go and do anything. If it is associated with hypothyroid features, then obviously the endocrinologist would put the patient on thyroxine. In a hyperfunctioning gland, radioiodine is one of the prime modalities which can be given. AFTNs respond, autonomously functioning thyroid nodules or hot nodules respond very well to radioiodine. Other than that, if the nodule is benign, one does not need to actively pursue it or chase it. One can simply repeat an ultrasound after 6 to 12 months. You can alert the patient of symptoms as to what are the sinister signs they should be looking out for. If any of them happen, then they can come back to you. Otherwise, you can just follow up the patient.
So, Dr. Agarwal, how would you manage this case surgically if it turns out to be malignant?
So if it turns out to be malignant, then we have to see which kind of malignancy it is, whether it is of follicular cell origin or C cell origin, like medullary carcinoma, which are common presentations, and depending on the findings.
No, we are not discussing medullary at the moment. So let's say
so
it is
if
a differentiated.
We keep it to differentiated thyroid carcinoma, then
Yes.
if it is a proved malignancy, then we have to evaluate the extent, local extent, as I said, with ultrasound, whether it is associated with the lymphadenopathy or not, and if there are any signs of local invasion, involvement of the recurrent laryngeal nerve or trachea. If they are so, then we have to further evaluate by bronchoscopy, upper GI endoscopy, indirect laryngoscopy. If not, then maybe we can proceed to surgical management, and I would prefer to do a total thyroidectomy in these cases.
So when do you do total thyroidectomy, or when do you do lobectomy, and when do you do total thyroidectomy followed by radioactive iodine and central dissection? If you could just briefly mention.
So basically we divide these kind of early stage or small size tumors into low risk and high risk malignancies, and if or papillary microcarcinoma. So if it is less than 1 centimeter, it is papillary microcarcinoma. Mostly lobectomy or hemithyroidectomy is a good enough surgical option. Between lesions measuring 1 to 3 centimeter with no extrathyroidal extension and no lymphadenopathy, again hemithyroidectomy or total thyroidectomy is a debatable issue, and the reason of doing hemithyroidectomy is because of the risk associated with surgery compared to the benefits we get. If you are a high volume surgeon, definitely you can go for a total thyroidectomy if you feel the risk of recurrent nerve injury and parathyroidectomy are low in your center. This will better help in follow-up of the patients. But if you think you are a low volume surgeon, probably a hemithyroidectomy would be a reasonable option. And of course, for tumors larger than 4 centimeter or extrathyroidal extension or associated lymphadenopathy, you have to go for a total thyroidectomy plus minus neck dissection.
All right, we finished time, but I have a last question. I can put this question to Dr. Damle before the audience. How would you follow up following surgery these cases? When do you say the results are excellent? When do you say they are indeterminate? Or when do you say they are partial surgical or partial biochemistry?
Okay. So basically, as Dr. Vivek has put it, there are risk stratification systems. The American Thyroid Association classifies thyroid cancers into low risk, intermediate risk and high risk. The European Thyroid Association classifies into very low risk, and high risk. So the low and the high risk in the European classification and the intermediate and high risk in the American Thyroid Association classification of 2016, they have to be referred for diagnostic scanning and SOS therapy. Some literature says that a post-operative whole body scan is not required if these things are already known. But in the country, by and large, today we follow a system of doing a diagnostic scan, seeing whether the disease is restricted to the neck, that is only remnant tissue is there, or if there is nodal metastasis, lung metastasis or bone metastasis. Now, if any of these are detected, then the dose of radioiodine that is given varies. For bone metastasis, we generally give between 150 to 200 millicuries, although the upper limit of the dose is not defined in literature. For lung metastasis, we generally give 150 millicuries in adult patients. For nodal metastasis ablation, we give 100 to 150 millicuries. We are also doing a study right now where we are assessing 50 millicurie versus 100 millicurie ablation success rates. And in simple remnant ablation, if there is just remnant thyroid tissue, we can ablate with 25 to 50 millicuries. So these are the doses. So according to the risk stratification, we have to decide whether we should ablate or not to ablate. As Dr. Vivek said, microcarcinomas, you don't need to do anything. Even the low risk category, ATA, you don't need to do anything. You can simply follow up the patient. A scan is also not needed at most times. Now, when we call the patient after 3 to 4 weeks of a good thyroidectomy, generally the TSH levels are more than 30, which is a prerequisite for giving radioiodine. Now, after the TSH levels achieved and the patient is kept on a low iodine diet, we give a diagnostic dose of radioiodine and do a whole body scan. In the whole body scan, we'll see the different sites of disease. So as I said earlier, depending on the site of disease, we will treat accordingly. At this point of time, we simply need to do a baseline thyroglobulin level along with an anti-thyroglobulin antibody. We need to remember that if the anti-thyroglobulin antibody is positive at this point of time, the TG is likely to get underestimated. The next follow-up that we do for the patients in differentiated thyroid cancer is after 6 months. So the patient comes at 6-month intervals, and we would do a whole body scan till the time we declare the patient as completely ablated. So complete ablation is defined by 3 things. Less than 0.3% uptake on a I-131 whole body scan, a thyroglobulin level undetectable or less than 1 on a non-stimulated TG assay and less than 10 on a stimulated TG assay, and no clinical or radiological evidence of disease. So if these 3 criteria are fulfilled, then we declare that the patient has been successfully ablated, the disease has been successfully ablated, and we put him on annual follow-up. So this is briefly how we manage differentiated thyroid carcinoma.
Thank you. Any other questions from audience?
So I would just like to make one additional point.
Yeah.
Sir had raised a very nice question regarding when we should do molecular testing in thyroid cancer. So the Bethesda category 3 and 4, that is the atypia of unknown significance, AUS/FLUS, and the category 4. So what happens is, there is a panel of tests which look for different mutations. So the most commonly used is what we call as the GEC, or the gene expression classifier panel. Now the main mutations that we look for here are the BRAF mutation. So BRAF V600E mutation. If this is positive, then the lesion has higher chance of being malignant and has a adverse prognosis in the long term. The other mutation is the TERT mutation that we look out for, which has a similar prognosis. Regarding the RAS mutation that he said, presence of RAS mutation actually goes conversely. So if you find a RAS mutation, the chance of it being malignant is going to be lesser, and the lesion is more likely to be an adenoma. So if you get a RAS mutation positive, either KRAS, HRAS, or NRAS, then you can simply stick to a lobectomy or a hemithyroidectomy, and a completion thyroidectomy is unlikely to be required. Conversely, if you get a BRAF V600E positive on this Bethesda category 3 or 4 nodule, then rather than a hemithyroidectomy, you can go with a one-step total or near total thyroidectomy. So in converting the type of surgery and giving you a better idea pre-operatively, this is useful. However, literature is widely variable. In the Eastern countries like Korea, they have described that this molecular testing has 80 to 90% sensitivity and specificity, and US and Canada literature is exactly opposite. They say that it does not have more than 10% or 12% sensitivity and specificity. So the consensus now is that it varies from country to country.
Yeah, it's similar to the places which are iodine deficient, they have more of follicular carcinoma. Similarly, the molecular pathology varies. So we are going to come to an end of this discussion. Any questions you can always ask me or the panel later when we have over a cup of tea. Thank you very much.